Good morning, Dr. Chauhan. This is the November 2021 meeting of the Capital Area Carcinoid Neuroendocrine Tumor Survivors Patient Support Group. And we're happy to welcome Dr. Aman Chauhan to our session today, who will be talking about PRRT. Dr. Chauhan is the Assistant Professor of Medicine and also Director of Neuroendocrine Tumor Therapeutic at the University of Kentucky Markey Cancer Center. Dr. Chauhan's clinical interests include treating neuroendocrine tumors, including carcinoid tumors, high-grade neuroendocrine tumors, and small carcinomas. As director of the Therapeutic program, he identifies patients who will qualify for PRRT, the Lutathera lutetium-177 treatment for gastroimperative Gepnet's tumors. I can tell you, those of us who saw Dr. Chauhan present when, I believe it was in 2017 or 18, when we did the joint program with down here in Virginia. He gave a wonderful presentation, and we're very happy and lucky to have you come back to speak with us again. Dr. Chauhan, you should be able to share your screen, so it's all yours.
Thank you, Barry. First of all, appreciate the invitation, and it's always a pleasure to interact with that patients and also discuss what I find very exciting and have decided to be a focus for my career, that is research in NETs and high-grade neuroendocrine cancers next. Let me share my slides today. Barry, can you see this? Okay,
yes.
Wonderful.
Yes.
So for today's talk, I would be focusing on a very specific topic, that are novel PRRT clinical trials. Neuroendocrine cancer is a huge topic, and we can go over days to discuss all aspects of neuroendocrine cancer, be it low grade, be it high grade, well differentiated, poorly differentiated, surgery, local regional therapies like embolizations, newer chemotherapies, targeted therapies, and radiopharmaceutical therapies. So it's just not possible to wrap it under one talk. But Barry invited me to give a talk about what's happening with the PRRT, since PRRT has been one of our newest kid in the block, and it's a very fantastic drug with really nice data, which I'll kind of show you. But the newer research kind of moves forward on the shoulder of the previous research. So we are trying to take PRRT to the next level, trying to improve on the current PRRT. And that's what I would be discussing a little bit on this talk. Have you heard of this term called Therapeutic? Some of you all probably have, and others might not have. So let me kind of walk you through what is Therapeutic. This whole field of medicine is coming up big time, especially last few years. This is a cover page from March 2020 on the Lancet Oncology, one of the very well-known medical oncology journal. And this cover page basically emphasizes the growing importance of theranostics. What you see here is a radionuclide, that ring kind of structure, that's basically a radioactive element. Then it's linked with a chain to a receptor analog or a peptide or some sort of drug, which then gets attracted to the cancer cells, right? So this is a very precision way of taking the radionuclide and dragging it and taking it to the cancer cells. What's the advantage of doing that? Our traditional radiation-based treatments, when we radiate somebody or a part of the tissue, there is just no way to completely avoid normal tissue. There would be some normal tissue exposed to radiation while we are trying to focus our energy beams on the tumor tissues. But by doing the precision radiation or theranostics, we can actually minimize the exposure of radiation to normal tissue by quite a bit. So let's talk a little bit more about this with regards to NETs. So as you all know, this whole field of theranostics really got a big shot of steroids in arm because of NETs, because of a drug called lutetium-177 dotatate that has now FDA approval for metastatic GAP NETs. So what happens here is, as we know, low grade or grade 1, grade 2 NETs often have a lot of somatostatin receptors on their cell surface. Now, some scientists made a drug which is called somatostatin analog. So analog is like a key, and somatostatin receptor is like a lock on the tumor. The key likes to go and sit on the lock, right? And that's when we inject somatostatin analog, it goes through the blood circulation and goes and attaches itself to the tumor. And the somatostatin analog locks into the somatostatin receptor, which is present on the surface of the cancer cells. Now imagine if this somatostatin analog is attached to a radioactive compound or a radionuclide, for example, lutetium-177. Then if you inject that particular drug, the somatostatin analog, which is the key, will go and find the lock, and the key is now attached to the keychain. The keychain is radioactive. So this is a way to now target the radiation specifically to the tumor cells and not some arbitrary normal tissue. And that's the whole field of theranostics. What is another advantage of doing this? So if you flip this radioactive material, you change the keychain from lutetium-177 to gallium-68, for example, a much lighter radionuclide, right? It's not powerful enough to radiate the cancer cells, but it is powerful enough to be detected on a PET scanner, right? So by same phenomena, we can actually diagnose the disease much better. We can uncover the tumors, right? So you've heard of gallium-68 dotatate scan or copper-64 dotatox scan. So these are radionuclide scans where we can actually see the somatostatin receptor positive disease. The only difference between that and the drug Lutathera is that we are using a much potent, much higher dose radiation radionuclide, lutetium-177. So a diagnostic phenomena can then be used to treat the patient's therapeutics. So that's the term theranostics or theragnostic comes in. It's diagnosis and therapy all sandwiched together. There is another drug which is coming up big time and is going to popularize this field of theranostics even more, and that's lutetium-177 PSMA, because PSMA is highly expressed in prostate cancer, and the same phenomena has been used where gallium PSMA scan first detects what's the burden of prostate cancer in the body, and then patients get treated with lutetium PSMA drug, which goes and find prostate cancer cells which are positive for PSMA and then radiates them. So Novartis studied this drug in a phase 3 study, which was a positive study. So we are awaiting the FDA approval for this compound, and prostate cancer being a very common cancer, this drug's going to be, I think, very popular in times to come. That reasons. However, this field of theranostics is not going to stop at NETs or, for that matter, prostate cancers. New targets have been now explored. And for example, FAP, fibroblast activating protein, this is a target which is present in many cancers, colon cancer, pancreas cancer, breast cancers, and many other cancers. So just like how somatostatin receptors are present in NETs, if you can find a target in any cancer, you can then detect that cancer by linking the analog to that particular target by gallium-68. So look at this, gallium-68 FAP agent is able to detect all these cancers. And now what we have to do is flip this gallium-68 to lutetium-177 to now treat these cancers. So this is again another place or application of theranostics where we can both diagnose and then later treat, as long as patient has those biomarkers. So I just wanted to walk you through this new emerging field of theranostics. Now let's come back and focus on NETs and application of theranostics in NETs. So NETs is not one single disease. Neuroendocrine cancer is a spectrum of disease, a group of disease. When we talk about neuroendocrine cancers of lung, this is how we classify them. Typical carcinoid, atypical carcinoid, and poorly differentiated neuroendocrine cancers like small cell or large cell neuroendocrine cancers. But analogous to this, the GI neuroendocrine cancers are very much similar too. Well-differentiated grade 1, well-differentiated grade 2, well-differentiated grade 3. And on the very extreme and on the aggressive spectrum, it is poorly differentiated neuroendocrine carcinoma, which again can be small cell or large cell. So the terminology is slightly different, but they are exactly the same in terms of their biological behavior. So the typical and atypical would be more synonymous with well-differentiated grade 1, grade 2, grade 3, and the poorly differentiated would be synonymous with the small cell and the large cells of the thoracic world. Now, why do we need to know about neuroendocrine cancers? Of course, the group here, either you have neuroendocrine cancer or your family members. So it's really good to stay updated in what's happening in our field. And actually, out of all the cancer patients, I feel that neuroendocrine cancer patients are probably the most educated about their disease type and most well connected, which is a fantastic thing and really helps them get the best care possible. And I don't know what it is about NETs, but I find that difference in the patient population. Now I see only NET patients, but previously when I was a fellow, I could see that difference between my breast cancer patients, prostate cancer patients, or lymphoma patients, and NET patients. NET patients are very, very educated in terms of their disease, which is always a positive. And I hope that this can spread to other tumor types as well. But as we can see in this graph, the incidence of neuroendocrine cancers in the United States is on the rise. In fact, 1970s, there used to be one neuroendocrine cancer diagnosis per 100,000 patient population. Now it is 7 or 8-fold higher. While at the same time, the incidence of major cancers, be it colon cancer, breast cancer, lung cancers, has actually declined, while the incidence of neuroendocrine cancers has risen 7-8 folds. What is even more concerning is that majority of neuroendocrine cancer patients have grade 1 or grade 2 neuroendocrine tumors. They are slow growing cancers. So the prevalence of the disease, prevalence means the total number of patients with any particular disease at any point in time. Incidence means the new diagnosis in that particular year. So the prevalence of the disease, because patients from previous year's diagnosis keep accumulating, because patients live for longer time with this disease, the prevalence of disease is markedly disproportionate as compared to incidence. So based on incidence, we are still a rare tumor, 7 or 8 cases per 100,000. But when you look at the prevalence, neuroendocrine cancer of GI tract is actually second most common cancer of GI tract after colorectal cancer. We are higher than gastric cancer, higher than pancreatic cancer burden, esophageal cancer, hepatobiliary cancers. An amount of focus which is put on these cancers in their drug development is significantly higher than neuroendocrine cancers. So we really need to change that. We need to bring the focus back on neuroendocrine cancers, because together, if you count all neuroendocrine cancers of GI tract, we far outweigh the other GI cancers. And if we don't advocate for drug development research in neuroendocrine cancers, then we'll be always lagging behind in terms of new therapies. However, because of this recent awareness about rising rates of neuroendocrine cancers, rising burden of neuroendocrine cancers in the US, there has been some advancements in the therapeutic drug development in this particular space, which is very welcome. I remember when I was a resident in LSU with Dr. Waldring and Dr. Boudreau and Dr. Wang's group at that time, there were hardly any drugs for management of neuroendocrine tumor at that point of time. Now, compared to fast forward 2021, we have many options at this point of time to treat our metastatic progressive patients. One of the drugs which would be our focus on today's talk is Lutathera, the lutetium-177 dotatate. So what I'm trying to show here is the results from the phase 3 international clinical study called NETTER-1. This is the study which led to the FDA approval of Lutathera in the United States. Lutathera, or PRRT, was actually in practice in Europe for many years prior to that, 10, 15 years. But the access of this drug in the United States were limited. I personally know patients who had to actually go to Europe to get this drug because it wasn't available in US unless you were a part of a clinical trial. So, and this is such a great drug. It was sad that we didn't have access to this drug. Now, this particular clinical trial paved the way for its approval in the US, and now many patients in the US can benefit from this drug. In fact, as of now, 200 sites in the US, including Canada, administer Lutathera. So what is this drug? This is lutetium-177 dotatate. This particular radiopharmaceutical drug tries to find somatostatin receptor positive disease in your body and then radiates it, right? How do we know whether the patient qualifies for this drug? The patients with well-differentiated gap nets can get a scan, either gallium-68 dotatate scan or copper-64 dotatate scan, to look for somatostatin receptor positive disease. Now, if they have enough somatostatin receptor positive disease, that means a positive DOTA scan. If your doctor tells you, oh, yes, you have a lot of positive DOTA scan or DOTA avid lesions, then you qualify for PRRT, right? Because you have a lot of targets, which are somatostatin receptors. So in this particular study, half the patients got Lutathera, the green arm, the green lines, and the other half got a higher dose of somatostatin analog. That at that time was considered as the best standard of care. So what you can see here is the progression-free survival. So these patients were then monitored by doing scans. And at the time when this article was published in New England Journal of Medicine, one of our top journals by Dr. Strasberg, you can see the median PFS. That means on an average, the number of patients who might have progressed didn't even reach, while the median PFS was 8.5 months in the control arm. Now the long-term follow-up data is available, and we know on the Lutathera arm, on an average, the median PFS was 29 months. Compare that to 8.5 months. So the drug is significantly better than the control arm, and that led to its FDA approval. I don't think any other drug had such a dramatic benefit over the control arm, at least in the NET space. So this by far seems to be the most effective drug that we have in the NET space. However, we don't have a head-to-head comparison of somatostatin analog versus PRRT versus Afinitor. So I cannot say definitely, but if you look at this data and compare it to the data of other studies looking at Afinitor or somatostatin analog, none of those studies showed such a dramatic difference between control arm and the study arm. So this paved the way for the FDA approval of this particular drug. And since then, it's been in use widely. I'll share an example for one of our patients from Markey Cancer Center. So here, if you can see my mouse cursor, this is the baseline scan. The patient presented with a lot of metastatic disease. Every tiny black spot that you can see here is actually a deposit of tumor. And you can see almost all the bones in the body are actually infested by metastatic disease. You can imagine the patients in excruciating bone pain from the bone metastases. There are also a lot of liver lesions, etc. So this is what's called a gallium-68 dotatate scan. This helps us to uncover the somatostatin receptor positive disease, and this kind of gives us a lot of details as compared to CT scan or MRI, especially with the bone mets, right? Then the patient qualified for PRRT. We gave dose 1, dose 2, 2 months later, dose 3, and dose 4. This drug is given up to 4 doses if patient can tolerate it. And at the end of the treatment, the post-treatment dotatate scan, as you can see, significantly better. So to put it into objective terms, there was 63% reduction in TBI or 65% reduction in molecular tumor volume. That is significant. We just don't see disease shrinkage with somatostatin analog or Afinitor to that extent. So this is a very effective drug in shrinking the tumor down in some patients, especially in the bone mets patient. It helps a lot with the bony pain. This patient had a significant improvement in their quality of life because the pain improved quite a bit, okay? And moreover, the disease burden also improved. So that was very, there is one of the success stories that I wanted to share from the PRRT era. So I want to show you this iceberg here. And what I'm trying to symbolize here is now above the surface of water, PRRT is now mainstream. We have the access to this amazing drug for the patients who might be good candidates for it. A few years back, I could not have said that, right? So that is good. But should we be satisfied at this point of time? No, because underneath the surface, we still have a lot of other aims, goals, and we cannot be just happy with what we have. It is a significant improvement from the past, but median PFS of 29 is not where we want to stop. We want to stop at cure. Hopefully in decades to come, maybe we have a cure for this. But at this point of time, we need to now do better than what we have. We need to improve the disease stabilization. We need to improve the amount of shrinkage that this drug can do, okay? So the term here you see ORR, objective response rates. This is what we researchers use to calculate how much tumor shrinkage happens on the CT scans when we assess patients in clinical trial. So in the NETTER-1 study, although the drug is fantastic in controlling the disease or stabilizing the disease, as you know, the PFS was close to 30 months, right? However, when you look at how many patients actually the disease shrank, it was 17 or 18%, right? Now, to put it in a clinical perspective, previously somatostatin analog, the ORR is 5%. Afinitor, the ORR is 7%. So this is a big step towards positive. We are now in double digits. So the number of patients experiencing disease shrinkage are close to 20%. However, can we take it to 30, 40, 50, 60%? The majority of patients show disease shrinkage, not just disease stabilization. So those are some of our goals moving forward for next several years. So how are we going to achieve those goals, right? So we already have this drug, lutetium-177 dotatate, approved in 2000. But to improve on to the current PRRT, lutetium dotatate, some people are exploring newer types of PRRT, like alpha emitters. You might have heard some of the new PRRT agents. Instead of lutetium-177, they'll be using another radioactive nuclide, actinium or something else, which emits a different type of radiation. Instead of beta radiation seen in lutetium-177, alpha emitters, there was a little different energy wavelengths, etc. So some researchers are looking at different products. Some researchers are looking at a different type of PRRT which targets a different receptors. For example, lutetium-177 dotatate targets somatostatin receptors. I mentioned that there are some newer agents which targets FAP. So there are newer targets being developed which kind of benefits NETs and other cancers as well. Where I am personally invested is the combination of lutetium-177 dotatate with a radiation sensitizer. And that's what I'll kind of walk you through. So this is the route that I have decided to take, where we build on the success of lutetium-177 dotatate and add something to it to make it even better. And that's the hypothesis. So having said that, with that sort of goals in our mind and rationale, we at Markey Cancer Center have developed 3 clinical trials, which are combining lutetium-177 dotatate and some novel agent along with it to help improve the effectiveness of lutetium-177 even further. And these are some of the trials that I would be now discussing with you all. The first study that is looking into the combination is combining a drug called Triopine, which is an oral pill with Lutathera. Okay, so what is Triopine? This drug is actually not very new drug. This drug was originally developed at Yale University many years back, maybe close to 15 years. And this drug is a light chemotherapy drug by itself. So when the investigator first developed it, they tried it in various cancers. So far, 14 or 15 clinical trials have been done with this drug. And unfortunately, it didn't seem to be as effective when used by itself. This drug comes in both IV and oral form. So the one which we are using is the oral form because the pills are easy for patients logistics wise. You don't have to come for IV infusions. So what does this drug do? So with this diagram, I'll try to explain what are we trying to achieve here. The way the Lutathera works is the radiation of Lutathera causes breaks in the DNA of cancer cells. Okay, so if you remember, DNA is a double-stranded helix, right? It's a coiled double-stranded helix. And if you cause damage to the DNA, the cell dies, right? But after the radiation treatment, we know the cancer does come back. It might take longer to come back, but it eventually comes back. Why does that happen? Because the DNA of the cancer has powers to repair itself. And that is one of the problems. When we give chemotherapy or radiation therapy, it causes the DNA damage and most cells dies, but some cells survive and the cancer comes back. One of the reasons for that is the DNA of the cancer cell repairs itself. And what we are trying to achieve by giving Triopine is to slow down or stop that repair process. So Triopine is very important in blocking the manufacturing of building blocks of the DNA in the cancer cells. So it is a ribonucleotide reductase inhibitor. This particular enzyme is needed for production of building blocks of DNA in the cancer cells. So if you block that, you slow down the process of repair. And that's what we are trying to shoot for. How do I know this would work? Well, a clinical trial was done in gynonc patients and cervical cancer patients, right? Where Triopine was added to chemo and radiation therapies with the same rationale that, hey, chemo and radiation is going to kill cancer cells, but these cancers come back and Triopine is going to try to prevent that from happening. And when this study was done, you can look at the data, it's out in public domain. 96% patients had durable complete responses at 20 months. That's a big number. And now we have even longer term follow-up data from that study, 80% disease-free survival at 3 years. So the drug Triopine is definitely a very potent radiation sensitizer. And this was my cue that, hey, if this drug is working so well in gynonc cancer patient, why don't we give it a try in NET patients? Anytime we have a scientific rationale or hypothesis, we don't just straightway go to humans. We first try to prove it in mouse models. So we tested in some of the pancreatic neuroendocrine models, and what we saw, yes, by adding Triopine to radiation did kill more cancer cells as compared to radiation alone. So that was our hypothesis going into it. And we approached NCI to give us some funding and the drug to conduct this first in human clinical trial where we would combine Lutathera, which is standard of care, with oral Triopine. Okay, and we started this clinical study about a year back. It is a phase 1 study, dose finding study, where we trying to look for what would be the safe dose of Triopine to be combined with Lutathera. So phase 1 studies are the first studies which are not only looking for, what they're primarily looking for, what's the right dose of Triopine which is safe, but also we try to look for some signs of effectiveness, whether this adds a little bit to the treatment efficacy. In this particular clinical trial, we tried various doses of Triopine. We started at 100 milligram and then we moved up. And based on if some patients don't do well, then we have flexibility to move down as well. And these are what typically phase 1 trials are trying to do. Besides looking for what's the safe dose and some effectiveness parameters, disease shrinkage rate, etc., we also built in a lot of really interesting science into this particular clinical trial. We are looking for tumor genetics. We are trying to figure out why some patients benefit more from PRRT as compared to others. Is there something in their tumor genetics that makes them a little bit susceptible to the treatment? We are collecting some blood samples for circulating tumor DNA assessment to see whether we can do a quick blood test to assess for the treatment response. So a lot of interesting science is involved in this, and we are just very glad to NCI for the generous funding to be able to do this clinical trial. And this is my phase 1 group at Markey Cancer Center, which helps us conduct these novel early phase clinical trials. And this is after the first patient we treated. At this point in time, again, this is my first patient actually on this clinical trial. We won't be disclosing any results of this clinical trial. We are hoping to present some of this data at next year big ASCO meeting. But just to kind of give you some flavor of what we are seeing, this is the first patient we treated on this particular trial. And, we saw 35% disease shrinkage. These are the tumors. On the yellow is the original tumor and the blue is the post-treatment tumor. So here you can see the radiologist read is as 35% disease shrinkage. At this point of time, I won't comment any further. Could this be a beginner's luck, my first patient on a clinical trial, or this combination truly works? We will know more next year when we finalize our data and then we disclose it. However, it is very promising, and that was the reason why we were conducting this trial, and to see if we can see some of these superior disease shrinkage rates, etc. So that study is still ongoing. These NCI studies are open at wider network. So for example, we are the lead site, but that study is also open at Ohio State, Huntsman Cancer Center, Utah, Mayo Clinic, Rochester, City of Hope in California, and Northwestern University. So I have collaborated with investigators all these sites so that patients, not only in Kentucky, but other regions of the country also have access to that clinical trial if they want. So that trial is accruing very well and should be finishing up very soon, maybe in next 1 to 2 months. The next study, which is sort of continuation of what we're trying to do, is the combination radiation sensitizer, is this recently launched study. So unlike the other study, which is already about a year in, this particular study is about 2 to 3 months old. In fact, we are the only site right now in the country which opened so far because we are the lead site. So we had a little bit early heads up, but I'm very hopeful that again, this particular study would also be open at various sites, including Mayo Clinic, City of Hope, Huntsman, Ohio State, and many others. So this particular study is using a drug, which is a very new drug, unlike Triopine, which has been there for 15 years, and we're just trying to figure out how to best use it. This particular drug called peposertib is a very new drug. In fact, when I first started working with this drug, it didn't even have a name. like a year and a half back. It used to be called M3814, very new drug. And this drug is a DNA PK inhibitor. Unlike Triopine, which is a little bit more broader shotgun approach where we are trying to lower the building blocks of DNA material in the cancer cell, the DNA PK inhibitor is a very precision, sharp, targeted therapy, which is only specifically blocking an enzyme, which is directly linked to DNA repair. So the advantage of this particular therapy is that it does not have off-target effect. So that means it's just going to focus on DNA PK and would not affect other processes in the body. So it does not have a chemotherapeutic role by itself. So if I give this particular drug to a patient or a animal model with cancer, it would not do anything. It is not a chemotherapy drug by itself. But if I combine this with a radiation based treatment or chemotherapy based treatment, which damages the DNA of the tumor cell, then it is a very potent anti-cancer drug. Okay, so that's the brief summary of this drug. This study was one of my first studies when I was developing or starting my career as an early drug developer. In fact, I started working, finished my training in NETS in July. So I landed this grant to study this drug, and we got this package shipped from Germany of this brand new drug. So you can understand my excitement. These are some of our mice models where we are trying to grow pancreatic neuroendocrine tumors in the thighs of the mice, right? So this bulge that you can see, these are actual tumors, which are human tumors, but grown in the mice, right? And then we drug the mice with this particular drug, which is an oral drug. So we feed the mice the drug, and then we do the radiation treatment. You can see the radiation being targeted here. And what we saw, this is my group, the radiation doctor, the basic scientist, and that's me. And what we saw is, this is in vitro data, that when you added peposertib to the mix of the cancer cells, we saw more cancer cell deaths as compared to no peposertib. So it certainly seems to be very effective. Here you can visualize even better. These are actual mouse model tissues, right? So when we added radiation and peposertib together, that group of mice showed the significant reduction in the tumor growth. Look at this tumor sizes. It had no growth whatsoever as compared to if just radiation by itself. And as I mentioned before, when we did drug by itself, the drug by itself does not work, right? That's the mechanism of action. The drug needs something to damage the tumor DNA. That can be in radiation or chemotherapy. So when this drug was added to radiation, you saw a significant improvement. This was very profound, very encouraging. And I presented this data at NANETS as well back in 2019. Now, we approached NCI to fund this study so that we can now conduct a human study to confirm that we are seeing these dramatic improvements in the tumor shrinkage and anti-tumor effects. And very similar to our Triopine study, 4 doses of Lutathera, and peposertib is an oral pill which is given for 21 days during each dose of Lutathera. The idea is that every time we give you Lutathera infusion for that 2 to 3 week period, the Lutathera infusion causes DNA damage in the tumor. And if we back that up with peposertib pill, we prevent the DNA repair. So we kind of put the cancer in longer remission. And that's the main rationale of the study. The study is now open. We've treated the first 3 patients. And I'm very hopeful that other colleagues at other sites in the US would also be opening this study very soon. So happy to bring these 2 studies with a combination. And the third study, to wrap up today's conversation about novel PRRT trials that we have designed here at Markey, is looking at a drug called telitrestat ethyl. Now, some of y'all might have already heard of it or might be using it because it is an FDA-approved drug. One of the problems with NETs is a small minority subset of NETs patient can make very excessive level of a hormone called serotonin. It's about 20 to 30% patients who express high serotonin, and we call them functional neuroendocrine tumor patients. What does excessive serotonin do? Serotonin has multiple effects. It can give you bad diarrhea. It can cause bad flushing. It can also cause fatigue, joint pains. It can destroy heart valves to cause something called as carcinoid heart disease. It can cause fibrosis in the belly called mesenteric fibrosis. So having high level of serotonin is usually not good, okay? So this drug was designed to lower the level of serotonin so that the diarrhea can be improved. That was the main goal when this drug was improved. So serotonin is made in the neuroendocrine tumor cells by converting an amino acid called tryptophan, which we eat in the food, into 5-hydroxytryptamine, which is serotonin, through various enzymatic processes. And this particular drug, trilitrostat, which we know by name Zermelo, inhibits this tryptophan hydroxylase enzyme. So if you block the enzyme, you basically block the production of serotonin. If you don't have serotonin, you don't have those carcinoid syndrome symptoms, flushing, diarrhea, etc. Right? So, but that's for syndromic patients, right? And I mentioned before, that's usually 20-30% of all NETs. But what about majority of NET patients? We now believe that serotonin, maybe not in a very higher quantity, but even in a small minute quantity within the tumor microenvironment, a small amount of serotonin can promote tumor growth. And this is some of the data. When you add serotonin to the NET culture cells, it does promote tumor growth. So we believe that blocking the serotonin or lowering the serotonin can potentially also have anti-tumor effect or cytostatic effect, or prevent neuroendocrine tumor cells from growing. And based on that rationale, we build a study where we're combining Lutathera with 2 different doses of Zermelo, 500 milligram and 250 milligram dose. Now, 250 milligram dose is what's FDA approved in the US for carcinoid diarrhea control. But the clinical trial which led to its FDA approval, called TeleStar study, it looked into both 500 and 250 milligram dose. The diarrhea reduction was similar in both the doses. However, if you look into the serotonin reduction, the urinary 5-HIAA reduction, that was much higher in the 500 milligram dose. So this study is not designed for diarrhea control. This study is looking at tumor control. And if we are looking at tumor control, we had to evaluate something which can potentially lower your serotonin even more to have better control. So the study is sponsored by Tercera, covers the Zermelo for both the study arm. The Lutathera is per standard of care. And we are trying to look for additional benefit of adding Zermelo to control the tumor growth even better at 20 months. And besides that, we are also looking at quality of life assessment. Does it improve the fatigue, energy level, and other assessments, indices of quality of life? And with this last slide, I would like to wrap up my talk, and then we will open the floor for questions. This slide just emphasizes that Therapeutic is not just for NETs or one particular tumor, or this whole field is not just rotating around or gravitating around Lutathera. As long as you have a target, and we can then design a drug to target that particular receptor, we can target any cancer tumor type. This is a patient which was referred to me from, I won't disclose the location, but from far off. And the patient had a positive gallium-68 dotatate scan. This is not a neuroendocrine tumor. This is esthesioneuroblastoma. So many cancers can express somatostatin receptor, NETs being one of the common ones, but there are some other tumors which can express somatostatin receptors. So as long as the patient, so you can see the skull bone, the spine, the hip bone had a lot of disease, the patient has a lot of symptoms. So as long as you have a target and we have a drug which targets somatostatin receptors, this drug should theoretically also help other patients. So we treated this patient, we got access to Lutathera, and the patient's doing now phenomenally well. So this is the promise of precision radiopharmaceuticals, the targeted radiopharmaceuticals that hopefully in future we can make them even better by adding newer novel drugs to them or defining better targets. But very, very interesting and upcoming field. And this has all happened in the last 3 to 5 years. So the field is advancing very rapidly. And with that, I'd like to thank for your attention and the invitation for having me here. And again, Barry, thank you so much for the kind invitation, and to your group members at CACNETS. I'm happy to take any questions. If there are other questions beside PRT, I'm happy to do that as well.
Doctor, thank you very much. And we really appreciate the presentation. Yes, we'd love to be able to ask a bunch of questions. I'm going to ask one, if I may, is take privilege here. You're doing several clinical trials, PRRT, with one other drug. And your last presentation was, your last trial was talking about using telotropset ethyl. Have you done, is anyone looking at a clinical trial where you're actually looking at a combination of 3 therapies combined rather than just 2?
That's a great question, Barry. So for this particular talk, I was focusing on the clinical trials that we have personally designed here at University of Kentucky Markey. And some of these are accessible nationwide as a multi-center trial. But we also have many other trials beyond these. These are industry studies which are open worldwide, etc. So these are not the only PRT studies that we have here. We have pediatric NETTER-P study, which for our pediatric patients, we recently started a pediatric NET program here so that our pediatric patients can benefit. And then we have many other clinical trials that are exploring. To answer your question regarding multi-drug regimen, the 2 or 3, more than 2, right now those studies are fewer. Anytime we combine drugs, the big thing that we have to also factor in, of course, we are always looking for efficacy. We want to improve the efficacy, right? So by adding drugs, we theoretically think that we are making the combination more potent. This will be more efficacious. But the flip side is we worry about the toxicity, that adding more agent can also be more toxic. So it is a fine line, right? So we have to always have benefit, more benefit, less risk, so risk benefit ratio should always be in our favor. And that's why many times we shy away from combining too many agents. So we first start with 2 agents, make sure they are safe. And then maybe in future we can consider. Having said that, certain cancers where our traditional therapies are not doing that great, the risk benefit ratio is opposite. We really are looking for better therapies, and sometimes we combine multiple agents. So without divulging more details, because this is still a concept in development, we are looking at a Lutathera combination study with 4-drug regimen in high-grade neuroendocrine cancers. This is not low-grade NETs. In low-grade NETs, Lutathera by itself does so well that we are trying to improve it by adding 1 more drug by an interesting mechanism of action of radiation sensitizing. But in high-grade neuroendocrine carcinoma, this is a patient population, highly unmet medical need. We don't have good therapies, and that's where, and the cancer is much more aggressive. So we need something better than what we already have. And that's where we are designing something with a combination, but it is not ready for prime time yet, maybe another 3 or 4 months. As soon as we have that trial open, we can then disclose it to the public.
Thank you very much. Nan, I'm going to turn this back to you to manage the Q&A.
Sure. Dr. Chauhan, we have a few other questions that have come in. First and foremost, how does one apply for any of the studies at University of Kentucky?
Thank you. That's a wonderful question. And for any study for that matter, I want the viewers to know that the best resource to find any clinical trials is clinicaltrials.gov. This is a federally funded website maintained by the government, and all legitimate clinical trials should be listed in here. So if a trial is listed on the clinicaltrial.gov, you can be assured that this is not shady. This is following the compliance policies. And when you type in, let's suppose, neuroendocrine tumor, there are a lot of search words, just like you do Google search. So you can then tailor it. What studies are then open? You click on the open studies, or to filter out the closed study and all that. And there is a contact tab that will give you the contact information of that particular study. If any of these studies, if you click on that, it might give you contact tab. For me personally, I might have left my either office number or my email. However, for this particular group, I can just, let me type in my email ID directly. And if you can email me, I can then connect you to my new patient coordinator called Joy Haney. She is really good in communicating with neuroendocrine tumor patients. She is very experienced, been doing it for several years now. So that would be one way to do it. Otherwise, if you go to Markey Cancer Center website, there should be an information regarding how to set up an appointment with me. And the number is given there. Basically, it'd be Joy Haney picking up that phone and working with you to get your records and reviewing your case. And then we can assess the eligibility for this particular clinical trial. I was kind of giving a generic answer, how to look for other trials as well, because there are other trials ongoing at various other sites. But for this particular study, you can approach me and then I can plug you to Joy, because to look for any clinical trial, we have to really review your individual particular case, your history, your lab values, your functions, and your radiological findings, because there are a lot of nuances. However, I've personally had patients from outside the state, all the time. So it's not unusual to not see patients from outside Kentucky for these studies, because there are very few places who are looking for drug development in NATs. So we do cater these studies to patients from far as well, as long as they are able to travel.
Great. Thank you. Everybody, the information that Dr. Chauhan has posted is in the chat.
Dr. Chauhan, 1 second then. Dr. Chauhan, if you can send me not only your email, but the contact information for your study coordinator, send it to the email where we've communicated. If it's okay with you, I will post it on our group's website.
Wonderful. I think that would be better. So Barry, I'll introduce you to Joy Haney, and then that way you'll have her contact as well. And I apologize, the first email was wrong. It's actually .edu and not .com. But yes, Barry, that might be better if you can actually post Joy's contact, because that'll be much more smoother. Before we see the patient, we need all the records and the path, and we have our own dedicated NET tumor board. So we review all these cases here. So, but Joy would be great first contact person.
Great, thank you. Thank you for that. We'll be sure to make sure everybody knows how to contact her. Another question is, can these target therapies apply to NEC with a RET mutation?
That's a great question. So NEC is another area, as I mentioned, where we do need more therapies. We do have some clinical trials in NEC space. Now, as far as these specific clinical trials, these are not designed for NECs. And that's primarily because when we look at well-differentiated neuroendocrine tumor, 90% or more GI origin neuroendocrine tumors would express somatostatin receptors. When we inject these drugs, Lutathera, lutetium-177, dotatate, they can only target the cancer cell if you have those somatostatin receptors. If your cancer cell doesn't have them, then they have nowhere to go, and the key has no lock to find, right? The high-grade neuroendocrine carcinoma, NEC, the percentage of these patients who have somatostatin receptor are significantly low. The published literature suggests maybe 20%. So that's much less than the 90% range that we see in well-differentiated. So these clinical trials are designed for well-differentiated NET for the PRRT. Having said that, many times, if we are running out of standard option for our high-grade neuroendocrine cancer patients, or none of our current clinical trials designed or targeting high-grade neuroendocrine cancer patients are exhausting and we don't have much options left, I sometimes try to do a gallium-68 dotatate scan to look for those somatostatin receptors in our high-grade patients. I do tell my patients that the chance of finding the receptors are not very high, but 15-20% is not that low either. So if somebody has high-grade neuroendocrine cancer, NEC, and has DOTA positive PET scan, then yes, we can try PRRT. It is not FDA approved. We will have to then fight the insurance and try to get the access to the drug. There is a clinical trial called NETTER-2, which is also open here, that is looking at grade 3, including grade 3 neuroendocrine cancer patients for Lutathera, but grade 3 well-differentiated NET, not the poorly differentiated. So for poorly differentiated NEC, if you have somatostatin receptor positive disease, as noted on either a baseline copper scan or a gallium scan, then we can try to fight with your insurance and get a Lutathera approved for you. Remember the last screen I showed you, that patient benefited from Lutathera. It wasn't a NET patient, so it was an off-label use of Lutathera. It was a rare tumor type, and the patient had exhausted all the options. So if you have a target and I have a drug, I would try my best to fight with your insurance to kind of get access to it. Clinical trial is the way forward because we get easy access to it. And we also learn from that experience. But sometimes, not every small subset of neuroendocrine cancer patient would meet the trial eligibility. That doesn't mean that we shouldn't treat if we have a drug for them. But I do want to temper the expectation that the percentage of patients with gallium positive scan and high grade is very low. So that's why it is not a routine that we offer PRRT for NEC. Having said that, there are some NEC specific trials that are open here at Markey that we are looking at. And many a times NEC patients can also benefit from phase 1 clinical trials open at big, large cancer centers, including Markey as well. So that can be looked into for individual patients.
Great, thank you for that answer. One last question, unless something else pops up, and it is not about PRRT, but we know that you've spoken about a new philosophy about using octreotide during surgeries. I wonder if you could share some of that with us.
Yes. So that's kind of stepping aside from the PRRT for a bit. I was mentioning earlier, the well-differentiated neuroendocrine tumors, there are various ways to classify well-differentiated NET based on the grade. So grade 1, grade 2, grade 3, that's based on how the pathologist classifies them, right? The other way to classify neuroendocrine tumor is based on the site. So gastric NET, small bowel NET, rectal NET, so pancreatic NET, based on where they originate. Another way to classify NETs are based on the capacity of neuroendocrine tumor to secrete certain hormones or vasoactive amines. So if the patient's neuroendocrine tumor secretes serotonin, we call them, and so serotonin producing neuroendocrine tumor. Some neuroendocrine tumors would secrete gastrin, some would secrete insulin, some would secrete glucagon. So there are various hormones that these neuroendocrine tumors can secrete. So the neuroendocrine tumor patients which secrete hormones are classified as functional neuroendocrine tumors. And those who don't secrete hormones, they are considered as non-functional neuroendocrine tumors. Okay. So fortunately, the functional neuroendocrine tumors represent the minority, maybe 20–30% of all neuroendocrine cancers are functional. So in the patients who have functional neuroendocrine tumor, the by far the commonest functional neuroendocrine tumor is the one which produces excessive serotonin, not the VIP, insulin, other hormones. By far the commonest is the serotonin producing neuroendocrine tumor. You've probably heard of Carcinoid Syndrome. This is what we refer to. Neuroendocrine tumors which secrete excessive serotonin can give the rise to some clinical symptomatology, including flushing, diarrhea, wheezing, fatigue, joint and muscle issues, pain, rashes, etc., etc. There are so many manifestations that it can cause. So that's called Carcinoid Syndrome. And what's happening there is the tumors are producing this hormone, which is giving rise to these symptoms. Now, when you operate or do any sort of procedure on these patients which are producing excessive serotonin, you always run a risk, or traditionally that has been a thought process, that manipulation of these tumor during the procedure, be it embolization or surgery or something, you can cause the tumors to splurge a little bit of serotonin during that procedure, okay? And then that rapid bolus of that serotonin released in the blood can cause carcinoid crisis. Okay, you probably also heard about that term, carcinoid crisis. So sudden surge of serotonin because the tumor was being manipulated, operated on, or some sort of procedure was happening. And if a sudden splurge of serotonin happens, what can happen is your blood pressure can go down all of a sudden. Your heart rate can go up, all sort of these hemodynamic instability can happen. So in medical oncology world of mine, we don't see this, right? This is the sudden part of it. It's crisis, usually seen during procedures. So this is mostly seen and documented in the surgical arena, surgery and the anesthesia world. So they call it carcinoid crisis. And the idea is when we are about to operate a patient with large bulky disease, serotonin producing tumor, high level of serotonin, we worry about this potential complication, okay? In literature, about 20–30% is the rate of carcinoid crisis during surgeries, okay? And that's based on the published literature. Dr. Palmier also suggests about 29%, I think, in his practice. And he does a lot of carcinoid surgeries in Oregon. So it is fairly frequent. I mean, 29% is not a small number, right? So many patients during the surgery or procedure are getting some degree of crisis. That's what it seems like for a non-surgeon, right? 29, 22, 30% rate. However, that might not be significant, that, life-threatening significant, but they probably noted some dip in blood pressure or tachycardia or something, but they did note, or this is the published data, 29, 30%. So historically, going into surgery for the patients, this type of patients with high serotonin, we used to preemptively give them somatostatin analog, the octreotide drip. The anesthesia would give it actually during the procedure, or they'll get a short bolus before the surgery as a preemptive measure, as a prophylactic to reduce the chances of developing the crisis, right? So it makes rational sense, right? So you are a high-risk patient to release a lot of serotonin during the surgery. So you're giving a drug which reduces the level of serotonin. So that makes sense. And that has been a practice in various US centers for past several decades. And I would tell you, even at Markey, we do that because octreotide is a very benign drug. It doesn't really cause any harm, right? It's a very safe drug. And in fact, in carcinoid syndromic patients are already on octreotide, the monthly long-acting octreotide. They get these once-a-month shots. So they're already on this drug. So why not give them a little bit extra during their big surgery to prevent any sort of carcinoid crisis complication? And that has been a thought process for various years and decades. Now, some people don't believe in it. Some people believe that, this can be eliminated. We don't really need to do it, right? Although there's no major harm, but there could be some delay, or, the fact that we have to give an extra drug and then we have to wait for anesthesiologist to do it. So just adds another layer of things. Really, otherwise there's no side effect of giving octreotide, right? So, but some people don't do it. And just 2 days back, we had a meeting where we had investigators from various centers. So the surgeon from UC Davis and MD Anderson, they don't do octreotide. Okay, even before Dr. Palmier's data was released, their practice was that they don't give prophylactic. At our center, we do a lot of neck surgeries. We give prophylactic octreotide because we believe there's no harm. If at all, there might be some questionable benefit, but there's no harm. So that was the thought process for our surgeon. What Dr. Palmier's data in this NANETS, he showed that, he first of all defined what is the rate of carcinoid crisis in his patient population, close to 29%. But his conclusion was that it doesn't matter whether you give the preemptive octreotide drip, it doesn't make any difference. So he, from his data, was suggesting that it doesn't help lower the rate of carcinoid crisis. Patients who are going to get carcinoid crisis will get it, whether you give that octreotide drip or not. And he also, in another meeting, on one-on-one conversation with me, he did tell, based on his experience, it also doesn't matter whether you're high serotonin going into the surgery. He has seen carcinoid crisis in the patients with low serotonin, while the high serotonin patient did not have crisis. So the baseline serotonin level might also not reflect or predict whether you'll get to crisis or not. So his punchline was that it's not needed. You don't have to get a short-acting octreotide before surgery to prevent carcinoid crisis. That was his conclusion. Now, will we change practice? I'll be discussing that data with my surgeons, right? My surgeon might say, hey, if it's not broken, why to manipulate it, right? So last time I had this conversation with my surgeons, they have a good track record, no carcinoid crisis, and they're doing so well. And if the very benign drug like short-acting octreotide is doing that, why to put a patient in even a questionable risk of crisis if this has been working so well for them for past 7, 8, 10 years? So they might still not change the practice based on that data. Also, this data is single center, single surgeon. So that we always have to also make sure that it's not just him, that these kind of findings are also consistent with other surgeons as well. So if we see more papers from other centers suggesting the same thing, that you don't have to get octreotide drip before the surgery to prevent carcinoid crisis, then that becomes more believable, rather than, he's a great surgeon, fantastic, and he's very smart, and really hats off to him for studying the carcinoid crisis so much detail. But you have to assess it in a fair manner, and what are the pros and cons. So as of now, some centers were already doing the same thing. They were not giving octreotide. Our center, we were doing. Many centers do. I think at NIH, before this data, they were doing it, if I remember correctly. So will I change my practice at this point in time? Maybe not. And again, it's the surgeon's decision. I don't even make that call. It's a surgeon who is operating on somebody. So if the surgeon feels more protected by giving a very benign drug like short-acting octreotide, and he feels that, it protects, then more power to him. Why not, right? There's really no harm of doing that. So that's my 2 cents about Dr. Palmier's data in NANETS.
What is your advice to the patient going into the procedure, given that there is this controversy? If we feel that we want it, how do we deal with the surgeon and the anesthesiologist who's about to do some procedure on us?
Right. Well, that's a great question. So a lot of things that we do in our clinic is actually catering to patients' needs. So if it was me, I would honor that wishes, but I cannot extrapolate how I do things to another physician. They might have very strong feeling and they might say, no, you don't know what you're talking about, right? But when the data is questionable or not questionable, they are open to interpretations and there are some pros and cons. I usually go by what patients want, because at the end of the day, we are serving the patients. And unless we are 100% sure that by doing this, we are not causing harm, right? Now, if I had data that giving this short-acting octreotide causes harm, then I would definitely, that we have to educate our patients that no, you don't know, this is how it should be. Now, if there's no harm and this is what we were doing and things were working fine all these while for like decades, now why to stop it? I don't have that convincing data. So I leave it up to surgeon and anesthesiologist how they want to do things. If a patient wants to insist on it, they should discuss with the surgeon. I can't imagine that surgeon would fight that. It's not worth fighting. This is such a benign drug. If the patient feels strongly, no doc, do everything that you can do. I understand that there is data to suggest that short-acting octreotide doesn't help prevent it, but I want it just in case if there is even a questionable benefit. I can't imagine the surgeon would fight that, right? Because if there happens to be a carcinoid crisis, then the surgeon cannot backtrack and would feel, okay, I guess I should have done it. So that's why the doctor-physician camaraderie and that relationship is very important, right? And you should express your concerns, your fears, and sometimes the surgeons say, hey, I've been doing this. Like if you go to MD Anderson, they're also a net site, right? So they've been doing a lot of these surgeries and they don't give prophylactic octreotide. So they'll counsel the patient and they say, hey, we've been doing it for a while. And now we also have some data to support this doesn't help. So why to do it, right? So it depends on how that conversation between the surgeon and the patient goes. You might not be able to talk to the anesthesiologist because sometimes that conversation doesn't happen, or it's a very quick pre-op consent. But surgeon's going to be your quarterback, right? He's doing a surgery, so he needs to make sure you are comfortable. So have that direct chat with the surgeon and explain, that there is this controversy that what would you recommend? I would, if you are not biased either way, I would like to be on it. I can't see that the surgeon would fight you with that. I think at the end of the day, surgeon wants to do what the patient wants to do, as long as it's not harming you.
Yeah, thank you for that. I think that that's very valuable. We all have to sign consents before we go into our procedures anyway.
Yes, ma'am.
But I think speaking up for what we want is really important.
Oh, see, I see somebody posted a Carcinoid Crisis experience, and it can be very scary. So I'm glad the patient had a good outcome. Again, there is no foolproof way to reverse or prevent it. Short-acting octreotide is just another tool that we have that we often use. And with Dr. Pommier's data, there might be some growing consensus, oh, you don't need to do it, which is fair, at least there is some data. What his group did tell that the duration of crisis, however, was much shorter. In his group, they found it was about 3 minutes. Some studies have suggested 8 to 9 minutes. It's very rare to have crisis for this long, like the patient looks like a very severe case of crisis about several minutes into it. But on an average, Dr. Pommier reported that the average duration of crisis was under 5 minutes. I think maybe 3 minutes, if I remember correctly. So which is a good thing to know. And there are other things that we do when the crisis happens. Fluid resuscitation is the most important. So anesthesiologists and surgeon would be on top of it, and they would be giving some of these drugs to reverse, epinephrine and all those things are given. although historically that's also been considered contraindicated in carcinoma. But in crisis situation, Dr. Pomier recommend that you have to give these drugs to kind of restart the heart, get the heart rate going, get the blood pressure up, and give fluids and all those things.
Sounds like something we would all want to avoid if at all possible.
Yes.
I know I've experienced crisis also during procedures, and it's not easy, and the doctors had a hard time controlling it. So if there was a way to control it, I'd prefer that. Well, thank you so much. This has been an excellent presentation and question and answer period, and we thank you very much for your time.
Absolutely, anytime. Thank you so much for having me here. And I wish you guys all the best. And if we could be of any help, please feel free to reach out to us. We are here to help you guys. And again, Nan, thank you so much. Barry, thank you so much for having me over. And till we meet again.
Dr. Chauhan, thank you very much. I will follow up with you to get the contact information for your clinical trial coordinator, and everyone will get that posted to our website. I'm going to stop recording now.
Thank you.
Please check the chat, Dr. Chauhan. You have a lot of thank yous.
Yes, thank you so much.